So I want to tell you about the inspiration behind our work. The organisation I work for, we're not a clinical organisation. We predominantly support older adults in their own home. So we don't have nurses, we don't have healthcare workers, we've got social care practitioners. So the inspiration for the study that we undertook came a number of years ago when I was at a Scottish Care Tech conference and I first saw a SEM scanner. So I kept that idea at the back of my head. The train journey home to Inverness was absolutely filled with me reading all the information that was available at that time. And I kept asking myself the question, what if this works? What if it actually works? This could be a complete game changer in the world of care at home. Then an opportunity arose in the middle of COVID. I think it's important to say that when the world stopped, care at home mobilised. We probably worked harder than we've ever done. So the opportunity came around about some tech funding for social care providers in Scotland. Just to give you a sense of how the technology changed in the time when I first saw the SEM device, the one on the left of the screen is how the original device looked, and you can see how it looks now. This is probably an unnecessary warning. We're at a pressure ulcer conference, by the way. So I just wanted to flag that I'm about to show a picture of a pressure ulcer. So the key aims of our study were to prevent this. The human pain, the suffering, the indignity of pressure ulcers has to stop. They're avoidable. To give you a sense of kind of what the core pathway is in social care when we see redness on the skin, basically our care practitioners will see it, then we'll go to a district nurse, community nurse, we'll ask them to assess it, and then we follow the district nurse's advice. What this gave us the opportunity to do was something different. So basically our care practitioners utilised the SEM scanners, they got an objective delta score, and then, if the score was over 0.6, that was the call to action. The range of actions, not clinical actions, it might be, as you've heard a couple of times already, increasing hydration, looking at nutrition, mobilisation, elevating heels, yada yada. So the care practitioner takes that action, and then if we need then district nurse advice, that we would take it at that time. Just very quickly to let you know the process it went through, we developed an information leaflet so that people were clear about what it was that we were doing. We utilised a very, very simple screening tool. So this is Healthcare Improvement Scotland's 5-question tool. And basically, did it identify the high-risk group within Highland home carers? We could say categorically, yes, it did. And the reason that I'm so confident about that is that 37% of this cohort had had previous PUs. We also did a Waterloo assessment for each of the people, kind of just to prove that it doesn't work in a home care setting, because we don't have the ability to measure BMIs. If you ask people what their weight is, they'll tell you what their weight was when they were 20. And we don't have the ability to measure height. So we use this very simple screening tool, and what we added to the end of it was that people needed to have cognitive capacity to consent. It was really important to us. We were challenging a lot of structures as we were going about our business. I didn't want it levelled at us that we were using this scanner on people that couldn't consent. Consent form, pretty important. Also important, this SEM scanning device is marvellous, and you can imagine in a clinical setting, sits in a docking station, in a ward. That's not the environment we work in. And also in a clinical setting, if you think about the time that it takes to scan a patient, Basically, you know, the nurse will come, pull the curtains across, going to do your scan now, boom, we've done the scan, that's it, it's over and done with. Very, very different in somebody's home, very different. So first, they're a person, they're not a patient. We have to acknowledge that we've gone into their environment. We have to acknowledge any social things that come up when we're there. We have to travel to get there. We've got to clean, prep, record, advise, do all of these things. So it takes a long, much longer period of time in a domestic setting to do this. Had to do some problem solving because that nifty little docking station that you've seen is not something that we could transport around in cars. And you can see from the picture on the left, my original solution to transporting this bit of equipment was indeed a lunchbox. Eventually managed to find a medical grade case that it could fit in. And the case that we had, which was wipeable, had a hard outer shell, fits the device perfectly, was designed for a diabetes test kit. We developed a pocket guide. The SEM scanner is wonderful, but if you don't use it accurately, you won't get accurate results. So again, this is not clinicians that are taking these scores, so we developed this literally credit card size that would fit in their pocket as an aide-memoire if it was required. In terms of the data that we recorded, in hindsight, we limited ourselves because we used this form. There were a whole range of other kind of actions that we put in place. But you can see that for this person's score, that the readings were quite variable. That happened for a number of people, and quite often that was around about other social activities that were happening in their lives. So, you know, scores were better, for example, when they're out and about in daycare. Not rocket science, you know, it totally adds up. One of the things that I do want to draw your attention to is the score in the middle. So from the cohort, 29% had no visual discoloration on the skin whatsoever. And we had set ourselves, or I had set our organisation some pretty lofty standards. I wanted in this high-risk group to reduce pressure ulcers by 70% within this cohort. We reached 100%. Nobody in this study developed a pressure ulcer. Thank you. Thank you. Alongside that, because nobody developed a pressure ulcer, nobody went into hospital. And the health economic data stand for themselves. You know, there's the cost of the device, the cost of the disposables, linked to the cost of pain. How do you even put a price on pain? How do you put a price on avoiding pain? It's a hard one. Very quickly, this is some of my wonderful team of practice support technicians. This was a 3-cycle PDSA test of change. So at each stage, I asked the practice support technicians to do an evaluation. So we're gathering the data, we're evaluating, you know, are we going in the right place? We're making tweaks along the way. What was fascinating for me is in the first evaluation, this wonderful team said, yeah, it's a really great bit of kit. By the time we got to the third iteration of it, wow, they were saying, I feel really confident, I've got a new vocabulary, I know the language of tissue viability, I know how to give advice, not clinical advice, but advice within my sphere of practice. I know how to challenge district nurses. And at the point when we were involving district nurses, it was targeted. We were saying, okay, so we've got this Delta score, we've done X, Y, and Z, now we need you to prescribe prophylactic dressing or a different surface, so completely targeted. I promised you some stories, and some of these stories are absolutely amazing. So Number one on our study was a gentleman that we'd previously looked after in our hospital discharge service. We'd looked after him and his wife, and they came onto the mainstream care at home service when basically his wife had passed away. He became really, really sedentary, really depressed, didn't want to move. When we went in and started scanning him, he became so motivated by his own data. He started doing loops of his sitting room with his Zimmer. His conversation with his daughters, who were both ex-nurses, went from, oh, there's nothing on TV, the weather's really bad, to, I got a score of 0.5 today, haven't I, good boy? It was absolutely wonderful. And actually, when we think about data-driven healthcare response, enabling people to respond to that, you know, a lot of younger people wear Fitbits and, you know, we're charging around trying to get our 10,000 steps in a day. This data was a real enabler for the people that we supported. A couple of quotes along the way. The best bit was knowing that I wouldn't get sores on that part of my body. I really like to know my levels in the scanner so I could put my feet up. My feet are much better now. I have to say, incidentally, another unintended consequence of everything that we did was that families really engaged. You know, some families went out and bought vibrating foot plates for people. They wanted to be involved, to know about it, and yeah, it was just really marvellous. And this is a quote from a family member. For me, it was peace of mind. I live so far away, and I know what could go wrong. So finally, developed a standard operating procedure. I believe that this device could and should be used in care at home provision, and hopefully manage to pave the way for other care at home providers in Scotland to pick this up.